I love the show because you get a wide range of people, man. You get young kids, you get elderly, you get women, men. It's really cool from all over the world. So this next question comes from a 60-year-old gentleman. Love the doc segment. Keep them coming. My question is about prostate and lack of sex drive. I am 60 years old. I'm 6 foot tall and I weigh 210 pounds, up from 180. About 6 years ago, I started having a lot of prostate discomfort. I've always been pretty active, and after playing hockey or jogging, I would be in considerable in more discomfort. My urologist started me on finasteride, which helped me with about 80% of discomfort, but I still had some nagging pain. The doctor then added Flomax, and this brought me down to about 98% normal pain-wise. Still occasionally a little nagging pain if I'm very active. Symptoms free about 95% of the time, not a problem. No sex drive at all. No zest for life. No joie de vivre, as you would say. I knew you were going to say that one. I always had a very strong sex drive. Oh, you must hate it then. Up until I started taking finasteride. Not depressed, but just blah. And they give me some lab reports. So lab testosterone LC-MS-MS is 621 ng-DL and free 64.5 pg-ml. Testosterone bioavailable 135.5 ng/DL, PSA 3 ng-ml. Now more disturbing news. Triglyceride 251 mg-DL, cholesterol 248 mg-DL, HDL cholesterol 42 mg-DL. CHOL/HDL ratio 5.9, and CALC, LDL calculated 156 milligram /DD calculated. This is the first round of cholesterol labs that have been so bad. Doctors started me on rosuvastatin, calcium 20 milligrams, and all my cholesterol numbers are back in normal ranges. I had heard that estrogen level being off can cause prostate pain. I've also gained about 30 pounds since all this started back 6 years ago. I was 180 pounds, mostly weight gain around the stomach area. Being less active helps the prostate discomfort, but also hard on the weight. Ideally, I would like to quit taking the finasteride, hoping my sex drive would return. Alternatively, boosting my sex drive would be helpful. I had thought about HGH in low doses. I also thought it may benefit other issues such as cholesterol, weight. I hope it would also boost my sex drive. How might that affect my prostate? Any suggestion or other things should I be looking into? How would you determine the dose of HGH to start?
This is going to be a huge answer. Can I have that?
Yeah. That's why
I
I told you should
track
read
all
it.
that stuff.
All those data, man.
All right. Well, for starters, the fact that this gentleman is 60 years old and as of 6 years ago started having problems once he started taking a 5-alpha reductase inhibitor, the finasteride, which is known as Proscar or Propecia, depending on the strength. That's pretty telling. You know, I've talked about dihydrotest. Tell me if I have or not. Dihydrotestosterone before. I've referred to it as the caveman testosterone, right?
Yeah.
It also has all the negative side effects attached that we don't want to have on board, but it has something if we don't have any testosterone on board. In other words, it can give you libido, it can give you erectile function, it can give you energy, sometimes a little bit more with an edge to it, again, like the caveman edge, but it's better than nothing for a lot of people. And, you know, if you're hanging by a thread in terms of your amount of testosterone in your body, and then here you come along and for whatever reason, I'm not saying it's bad to take a 5-alpha reductase inhibitor, you do so, well, you just slash the last bastion of hope that you had for a libido, proper erections and everything. So that's why a lot of people complain about 5-alpha reductases in my practice that I've heard of anyway. So yeah, it makes sense that all of a sudden you've gone from feeling good to not feeling so good, though for a number of reasons. One is the bearing, I assume, of your dihydrotestosterone, this caveman testosterone. That's pretty conspicuous here for sure. The other thing, let's jump right to it, is the use of a statin. Okay, those numbers. I know the old standard of care is to use a statin for any number of reasons. Have we gone over and not just my view? I'm not some quack over here talking about cholesterol the way I do. I mean, there are articles printed that will substantiate a lot of what I talk about when I refer to cholesterol as the cholesterol myth. An article in 1982, the Atlantic Monthly, that's actually posted on my website about how the whole cholesterol myth got started. Have we talked about this before?
I don't think so.
All right, well, it's logical, right, to say that if you have, well, first of all, why do people care about cholesterol? Why does the doctor say, well, Dave, if you don't get your cholesterol down in 90 days, I'm going to put you on a statin.
Why?
You're going to have to clean it up with diet and exercise. Plaque. Okay, why? Because plaque is made from cholesterol, right? So it's very logical to say, okay, we'll get rid of plaque, we'll get rid of cholesterol, we'll get rid of plaque. That's logical. I have no beef with that. Nobody, at least the two of us in this room, can argue that, right?
Yeah.
But if I said to you, Dave, let's get rid of motor vehicle accidents, would you say by that same logic, well, then let's get rid of motor vehicles, Rand?
Yeah.
And that's nonsensical, right?
Yeah.
Or by reverse, if I said, okay, well, Dave, I'm going to dump a bunch of concrete, wood, and nails on your front lawn. Do you expect a house to grow itself? No. We know now, I mean, back in the 70s, it made sense, logically anyway, to go ahead and go this route. But now we know what the culprit is. What causes the plaque formation? You're a healthy athlete. You may not have it. I consider myself a healthy athlete. I've got a speck of plaque in my left carotid bulb here. Why? Because there's turbulence there. If you're not a total couch potato, it's like if you eat food, you're going to wear down your teeth. You're going to have some turbulence in these areas. Also, the widowmaker in the heart, the left anterior descending artery, there's a little bit of a twist, a torque in the heart. And so there's more turbulence in that particular artery. Well, turbulence creates some inflammation, which can lead to some plaque formation. Is it enough to prevent antegrade flow? In other words, is it abnormal? No. Again, I'm not all for normal, but is it something that is going to ruin you before something else does? No. So you're expected to see some wear on the teeth. You're expected to see maybe a speck in the carotid bulb. You're going to have some inflammation, but the answer here, bottom line, is not to get rid of cholesterol. There's a reason why we have cholesterol. These hormones we talk about all the time are made from, at least the sex hormones, the steroids, cholesterol, are made from cholesterol. There's a reason why your body is producing it. Your brain is largely made of cholesterol, and it's producing the so-called bad cholesterol, the LDL, as we speak. It's not bad, it's just more easily oxidized. Again, inflammation gets in the way and causes a problem. So one of the things is, and boy, I told you it's going to be a long answer.
No, it's good.
We probably can't pan over, but if people remember what my generation called the Krebs cycle, or what your generation calls the citric acid cycle, that's how you convert food and usable energy. Well, you need magnesium, zinc, a lot of the B vitamins, and coenzyme Q10 to do that, okay? Statins rob your body of coenzyme Q10. So another reason why this particular gentleman might feel kind of not so good is because he's on a statin. And why is he on a statin? Because they're treating numbers. The first thing I tell people is, now it's the 21st century and we had the technology in the 20th century. Why do we care about cholesterol? Plaque buildup. Well, why are we looking at a bunch of numbers to determine if you have plaque buildup? That's like saying, well, let's determine the population of Santa Monica based on the traffic out front. It's going to be different depending on the type of day, and it doesn't necessarily mean that's how many people live there, people who are commuting, right? I mean, I can go into all kinds of analogies, lousy or not, but you get the point. That's not the way. Bottom line is, let's look. We can with literally a wand, we call it, an ultrasound wand, a wave of the wand. We look at the carotids, which are important not to have blocked, okay? There's a 95% correlation between what we see in the carotid arteries and what are the coronary arteries. So why are we wasting time looking at numbers and guessing when we can just take a look? It's the same technology that we use to look at the fetus in a pregnant woman, okay? It takes, if the guy's slow or gal, excuse me, It takes a couple minutes on each side of the neck, and we can evaluate and see, okay, do you have plaque or not? If you're a 45-year-old male with high numbers and it's been that way your whole life and you don't have any plaque buildup, well then, okay, you're probably not at risk, certainly not what you think. Again, unless you pick up smoking 2 packs of cigarettes a day, drinking a handle of rum every night, and have diabetes or something, then, meaning unless you start creating inflammation, you're probably not going to have a problem. And this is a much easier test to do once every couple of years, or if you're, depending on what you find, you do it more frequently than guessing, looking at numbers. So again, I know that was long-winded, but it is important though, because the cholesterol myth is just that. Now, it doesn't mean that you don't want to look at some of these numbers. Triglycerides are 251. Probably eating too many starchy carbs or alcohol or something like that, at least within the few days before the test. And that should be trimmed down simply because you'll feel better.
Yeah.
Triglycerides will bump off oxygen from hemoglobin, the part of the red blood cell that carries oxygen to the brain and other parts of the body. So when you have high triglycerides like that, it tends to promote what we call food coma, postprandial narcosis. After you eat too much sugary foods, you kind of feel tired, or fatty foods. Estrogen, can it be the cause of prostate pain? Normally not, unless it's developed into cancer. We always talk about, estrogen. The issue with estrogen is not prostate enlargement so much as that we know it triggers the genes that all we male have for prostate cancer. So in that case, that goes to another thing. It's not the estrogen, but we might want to screen for prostate cancer. There's the Oncoblot test, which a lot of people don't know about, which is screening for pretty much all cancers, which I definitely recommend for everyone. Picks up on something called an ENOX2 protein, which only fetal cells and malignant cells will produce. And since we're not fetuses anymore, that would mean that you have some form of cancer. We can actually weigh it and check the pH and see where it is that you have cancer, what type it is, in other words. But the other thing that I want to get to here is there's a virtual prostate exam that you can take. It's using MRI technology. It's a multi-parametric MRI, and we can take a look at the prostate. He says he got relief from basically shrinking down the prostate by blocking DHT. What if you got prostatitis, which a lot of men have? It goes underdiagnosed. We don't know why we get it, but it's probably just from being on the planet longer than we were just 300 years ago when we were dead by age 28. Mm-hmm. But that's something you can check into that would have nothing to do really with dihydrotestosterone and prostate enlargement, although a chronically inflamed prostate will be larger than a normal one. But that's something I would definitely investigate. The other thing about feeling not so good is, you've got a ratio, numerically anyway, of 1% free to total testosterone, 600 to roughly 6, I think it was in here, the numbers. So something's off there, because the norm is typically about 2%. 600 is a pretty decent number, especially for someone 60 years old. But, as of about 2 months ago now, they published an international consensus on testosterone and testosterone replacement therapy. It was chaired by Dr. Abraham Morgenthaler, who's a urologist associated with Harvard Medical School. He's the man in the U.S., okay? So it was an international study, but it was chaired by a U.S. guy. I encourage everyone to read and I put a synopsis on my website, but you can look it up, Morgenthaler International Consensus on Testosterone, something close to that, and you'll see the full unabridged study results. And basically it says, look, what we've been talking about for a long time, you don't treat numbers, you treat people. So forget about trying to draw a line in the sand and say, okay, well, this is hypogonadal and this is not. If you're suffering signs and symptoms of hypogonadism, low testosterone, no energy, low libido, that lack of joie de vivre, and change in body composition. Here a guy has put on 30 pounds and went from 180 to 210. I'm assuming it's not muscle. Yeah, that's no bueno, as they say over here. So that's a sure sign. It sounds like, again, not seeing this person and not giving medical advice over the internet, but certainly leans to think, low testosterone here. So,
So he's obviously concerned to do TRT because of his prostate issue. Is the whole
well, you want to rule out prostate cancer in general, though.
Yeah.
Because testosterone is not the issue. Even once you have prostate cancers, urologists will say, the ones that I know, the progressive ones will say, well, gosh, the last thing we want you to do is get off your testosterone because we don't want you shrinking down and we don't want you to feel even crummier than you already do because you got a diagnosis of cancer and you're scared and you're going to start wasting away. The issue with cancer, and I've been through this thoroughly for a number of reasons, is really blocking the DHT. Again, so he's doing that, and we just recently cleaned up the whole idea about taking a 5-alpha reductase inhibitor, blocking the DHT and creating a more aggressive cancer. That's now been nixed. At least that's the latest, because they were saying, well, if you do that, then it's going to come back worse than before. No. So doing what he's doing in terms of blocking the DHT to sort of move along here, as I'm sure you're guiding me toward, that's not the problem. The problem looks like to me, he's getting 1% of the testosterone he's creating. We don't have an estrogen number, right? Mm-hmm. So estradiol, we want to keep at 15 to 20. There's a tipping point at about 21, 22 picograms per milliliter, where if we can get him down below that, then maybe he gets to 2% and he's got a 12 or 13 picogram per milliliter free T and he feels better.
Yeah.
Again, the problem is he cut his DHT and he already had low free T. So that was his last line of, of hope for libido and energy and all that sort of thing. So I still believe he should keep the DHT down, but let's get the free T back up and he might not have the symptoms. If that doesn't work, then consider testosterone replacement therapy. One of the things I've noticed over time, just sort of as an aside, is as you get older, even if I can get your free T up, it doesn't do as much for some reason. The receptors, I don't know. We don't know. Yeah. But you tend to have to need more to get the clinical benefit. Now, we talked about that before in terms of when you do get on replacement therapy, we've known since the 50s, you've got to get your total up to, and this is how long ago it was, we were measuring just total, but 80 nanograms per deciliter to get clinical benefit. 800 nanograms per deciliter is a pretty hefty amount of testosterone, and that's the minimum. Okay, so with replacement, we know we have to go higher. It may be because it's not about replacement so much as it is just with age. When you do have to replace, you have to go higher to get the clinical benefit. So I think I hit things to keep in mind for this gentleman. A lot of things going on. I think the heart of it though was the switch that dropped your DHT, and then the statin, which I'm not saying get off it, and I'm not giving advice over the airways here, the bandwidth, the band. But I would definitely look into. It's called a bilateral carotid Doppler ultrasound to evaluate intima media thickness. Basically, the fancy way of saying looking to see if there's any plaque in the arteries. In this case, the carotid arteries. And if there's not, then get off the statin. And I would even argue, even if there's some, depending on how much, if it's minimal or even moderate and controllable, then forget the statin. And if you're going to stick with a statin, you got to have the coenzyme Q10 supplementation, at least 400 milligrams a day with food to block the damage you're doing, which is why people always complain about statins, or usually the lack of energy and you're literally not allowing your body to create usable energy from food by leaching that coenzyme Q10. And probably the reason why his triglycerides are high is because he doesn't have the energy. And what do you do when you're tired? You grab a little something with some sugar in it, some things that satiate that. I think I covered everything here. I know that was a long one, but that was a long question. I think there's multiple factors, but easy fix. Just do a little digging, a little work.
All right. Thanks, Doc.